Welcome to the Dr. Lexi Show, where I take pregnancy topics and simplify them for you to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today we have a very special guest on our podcast. We have a neonatologist visiting us today. This is Dr. Matthew Abrams. Welcome.
Hey, thanks for having me.
Well, I want to make sure everybody that's listening knows what a neonatologist is.
Okay.
And if you can tell us a little bit about who you are and what you do as a neonatologist.
Sure. Yeah. So first, a neonatologist is somebody that's done training in pediatrics and then goes to additional training to specialize in taking care of newborns.
Yep.
So like I only take care of newborns, preterm babies and full-term babies. So we do 3 years of pediatric residency, the first year of which is called internship, but 3 years of residency, and then 3 years of fellowship. So essentially 6 years of training, and most people that do what I do only take care of newborns.
And when you say newborns, for people listening, what is that?
What range?
What is the range for that? Is it like once they go home, they're not a newborn anymore?
Yeah, it's a good question. So, starting out at say 23 weeks, so that limit of viability changes anywhere through full term, 40, 42 weeks. What a newborn is an abstract definition because physiologically there's no set cutoff. They say first month of life, is newborn. But again, if you're premature, you're a newborn for 5, 6, 7 months potentially. So where that ends truly is kind of a gray zone.
Okay. And you also mentioned the word viability, which is such a hot topic right now in so many places. So we're going to dive into that for sure, just to get a little more info about that. All right. So I have so many things to ask you. Okay. And I want to start with, if you want to tell us more about you, we can do that. And I know we know some, but I want to get into vaccinations because there are so many things. And full disclosure for me, I am a maternal fetal. Fetal is when they're inside the mom's uterus. When they're out, I hand them over to you guys, and my knowledge ends, in all honesty. And most OBs, I think, and MFMs would say the same thing, right? We've taken care of the mom and the fetus, and now we hand them to a neonatologist and then a pediatrician. I get questions in different towns I work in because I do telemedicine. So I'm in multiple different cities and states. How do I find a pediatrician? Where do I go? All this kind of stuff. And I know that even before you find the pediatrician, it's that period in the hospital of a lot of information.
Yeah.
And we as OB-GYNs and even maternal fetal medicine specialists, I know we punt sometimes where we ask the patient, talk to your pediatrician about these things, right?
We're great punters.
We're great punters. And I am in the space where I have the ear sometimes of someone to try to educate them a little bit more. It is hard for me to educate when I will say, I'm not well educated in that realm myself. And I should be, right? And we as the providers of people who are pregnant we have their ear for maybe 8 months, not the full 9 months typically, or, technically 10 months if you go the whole 40 weeks, but you know what I'm saying, during the pregnancy. And I want to talk about things that we can do for that initial couple of days. And then later, I want you to help me figure out the best way for someone to find a pediatrician.
Yeah.
So go.
That was more than a true or false question.
It was. But I want to start with the in the hospital, like when the baby's born, what are some things that a patient should already be ready for when they're in the hospital for those first 3 days of stay? I think that's where I'd like to start.
Yeah. I think just real quick, OBs or perinatologists, you take care of moms while they're pregnant. Pediatricians take care of babies after birth. We're kind of the in-between because we take care of, obviously physically take care of the babies after birth, but we cross over into the pregnancy when there's concerns or issues with the fetus, the baby before birth. And so we're kind of that, in a way, sort of middleman. At the same time, I think it's really good that you point that out because, parents have a relationship with an OB for 9 months. Let's talk about most, there's 4 million births a year in the United States, 140 or 150 million births year wide. More than 10% are term, right? Mm-hmm. So, which is good. Most kids aren't premature, but you have a relationship with the family or family has a relationship with you for 9 months. They've never met me or the pediatrician, right? Unless, they have other kids and that pediatrician also happens to be on that day or that pediatrician even comes to the hospital, right? There's a lot of trend towards hospitalists, right?
That. Yeah.
100%. So the talk to the pediatrician after birth is not particularly fair, right? It's you've punted something that could have been discussed multiple times during the pregnancy. And so there are things to expect after your baby's born. there are a couple things.
I'm going to interrupt you real quick.
Yeah.
Question for you. If I have a patient and it's their first pregnancy and they have so many questions about the neonate and the baby, the infant that I'm not equipped for, and I say, let's get you in to see a pediatrician or someone so that you can have a consultation before you deliver. Is that a typical thing that pediatricians or neonatologists are like, yeah, let's get you in before you deliver and do a consult so you can get to know me, establish care before this baby's born? Or do you have to carry in a child to be able to be seen at a pediatrician's
So
office?
I would say it's less common nowadays because of how practices are set up. It's a little less of that private practice. People tend to belong to bigger groups that are owned by companies. And you're not actually the patient. The baby would be the patient. So you get into some things because you are taking the provider's time. Now, some of the offices will offer like a night of what's the
a class or
like prospective parents, like where they have, or like they do it, like they'll do tours at the hospital. They'll have a group, like I saw a tour yesterday of like 10 parents, like 5 or 6 or 7 sets of parents coming in to tour the hospital. Sometimes they will go over those things, what to expect for your baby after birth. Some practices may have like a once a month, like come and get to know us, but you're not going to meet every doctor here. You may not meet the doctor that you wanted to, but we'll go over some of the basics of how our practice, get to know our practice kind of thing. We typically do consults when it's something that the baby's going to have something wrong or different about them, not usually routine stuff. Now, if somebody wanted that, we'd be happy to do that. Most of that information is readily available on the internet and through, other provider after birth. But I think less of that exists nowadays, that, going to meet a doctor to learn about that. And I guess it's okay because there are so many high quality resources, but nothing replaces that person-to-person conversation. And we know people are getting a lot of misinformation nowadays, right? We all want what's best for our kids, but some people are misguided in terms of what's best and how they're going to achieve that. So I think the classes at the hospital provide a lot of information. I think there are other basic resources and websites. I mean, nowadays it'd be uncommon, I think, to have a patient who doesn't have a smartphone of some sort, right?
Sure.
I mean, that'd be uncommon. So if they have that, they have a way of accessing the internet and getting information. I think providing people high quality resources is important. I would say in all the years I've practiced, I've never had someone say they just really would like to learn some basic stuff about newborns, either because they're too scared to ask or they've been able to address those questions otherwise. Sure. But I do think people should, pick a pediatrician before their baby's ever born. They should talk to their friends, their family. They should research it. Online reviews aren't a place to really look because most people don't write reviews about doctors. They'll write like, I went to their office and they were rude, or I got billed for this, and there's like 5 reviews, and this doctor has been practicing 30 years. So the best is to ask friends and family, who do they take their baby to or whatever. And sometimes there's good doctors with not good staff at the office, right? They have terrible scheduling people and rude people up front. Well, unfortunately, you're a great doctor, but I'm not coming to your office because I can't stand the people that work at your office, right?
Well, and a lot of doctors work for huge corporations almost, or big hospital systems. And so they might not have the ability to hire or fire someone who is at the front desk. So it might not be the best person that you interact with. And that's unfortunately the face of that doctor's office in your mind.
Yeah. Where I go see someone now is like a centralized scheduling for the system. And it's, I want the back phone, right? I don't want to talk to all these people. Just get me to the back person or let me text someone. Because now I'm spending 30 minutes of my time. Now they have ways of scheduling online through apps, which saves you time. But anyway, I do think it's important for families to know what to expect. No hospital wants to keep you in the hospital longer than you need to be. No one wants to kidnap your baby into a NICU. No one wants to take your baby away from you. No one wants to do that. No one is doing things to make money or increase revenue. People want the baby to stay with you and go home with you. That's what we all want. So, the things we provide that baby are for health reasons, right? So there are a couple shots or medicines your baby will get initially, and they're given for a number of reasons. Do you want me to go over those right now?
Yes, I do.
Okay. So one of the most...
because there's a few, right? There's not like 20. There's a few.
There's basically 3 things. So that are often given in the delivery room. and sometimes that bothers parents because they're like, oh, the baby was just born and now you're giving a shot and everything. And I get that. I have 5 kids. Again, I don't want my kids to feel pain and everything, but often this pain is very short-lived and has a number of benefits. So there's 3 things. There's that in general recommended for newborns. There's vitamin K, and we'll talk about what vitamin K is. Erythromycin eye ointment that is given to prevent what can be a devastating infection in the eyes, and the hepatitis B vaccine. I'll start with the simplest, hepatitis B vaccine. So the reason hepatitis B vaccine is given to newborns is because you can essentially vaccinate the whole population to reduce it significantly in the population. Now, years ago, you could get hepatitis B through blood transfusions. That's essentially eliminated nowadays. So you can get it through, secretions or fluids of another person, through drug use, through sexual contact. So yes, it's very unlikely a baby would ever be exposed to hepatitis B, if a mom isn't hepatitis B positive.
And that was my next question.
Yes.
Like if it's the whole thing of,
Right.
well, I got screened. I know that I don't have hepatitis B because that's a panel we do in
Right.
the OB office. Everyone is screened for hepatitis B.
Right.
So if the question is, well, I don't have it, why would my baby need to be vaccinated?
Right. So there's 2 populations. There's the baby who's born to the mom who has it. That's critical because that vaccine in itself actually reduces the risk of transmission by like 98, 99%.
Huge.
And that transmission occurs during labor and delivery, not beforehand typically.
And
Then
it's
there's
given quickly. Like when you say it should be in the first 12 hours?
Yeah, it should be for a term baby, we say 7 days.
Terms. Thank you.
Preemie, it's 12 hours. So there's that one group where mom does have hepatitis B and you want to vaccinate the baby, which also there's another shot for that, but that's really important. So, but that's very rare nowadays.
Yeah.
Once every couple of years we see that. And again, that most of those parents aren't going to decline that because that eliminates the chance that their baby's going to get hepatitis B, which can obviously cause liver failure and stuff. Then there's what most kids are getting hepatitis B for is to vaccinate the whole population with a vaccine that causes essentially no side effects. It's very rare to have a baby. I've never seen a baby actually have a side effect from the hepatitis B vaccine.
Mm-hmm.
It doesn't cause fevers. They're not uncomfortable for long periods of time, etc. Again, everything has potential risk, but this is
And
very
it's a shot,
safe.
right?
It's
Like
a shot.
This is not a nasal
Right.
something. This
It's a
is
shot
a
that goes
shot.
in the thigh.
Mm-hmm.
And essentially, that starts a sequence of 3 different shots in the first 6 months of life that essentially vaccinates you for life against hepatitis B. Say, well, my child's never going to get exposed to it. Well, what if you go traveling to some country and some continent that doesn't have the same level of blood product production that we have in the States? What if you go to some country, get in a car accident, and you need a blood transfusion? Years ago, people got hepatitis B that way.
Sure.
I can't verify the quality of production of blood samples in other countries. I mean, you go to Uganda, whatever it is, you're in some third world country and you need a blood transfusion. Do you trust the quality of that blood? If you're vaccinated against hepatitis B, you're not going to likely get it from that blood transfusion. So that's why it's given, because you can give it to essentially vaccinate the whole population.
Mm-hmm.
So that essentially every newborn in the United States could theoretically be immunized against hepatitis B.
Yep.
Are they going to get it as a newborn? Again, assuming we're not talking about the ones born to moms with hepatitis. Every other baby, are they going to get it at daycare? No, they're not going to get it that way. Can they get it in teenage
When
years,
they're
start having
older?
sex and drugs? Yes, you can. So that's the benefit there. It's a shot, but I mean, kids cry for like a few seconds. I mean, they cry after birth just from being born. Again, I'm not minimizing not wanting your child to be in pain, but it's not like they're suffering for minutes or hours. So that's one, is the hepatitis B. That's the simplest. We do have more people refusing that and either say, well, I'm going to do it at the pediatrician's office because I don't want my baby to get that now. You're giving them a vaccine right after they're born. We're going to do it. We're just not going to do it now. That's a reasonable alternative. The problem is when you defer vaccines too far or refuse them entirely,
Mm-hmm.
you get into, each one of them has different implications. We'll go to the next easiest, which is erythromycin eye ointment. So there are 2 bacteria that can infect a baby during labor and delivery that can cause some significant damage to the eye and even blindness. One is gonorrhea.
Mm-hmm.
Gonorrhea presents in the first couple of days. It's a nasty infection. It can destroy the eye and cause blindness. It's not the only bacteria. The other is chlamydia. Chlamydia takes longer onset, tends to not be as damaging, but can cause an eye infection. We call it conjunctivitis. Mm-hmm. There are also there are viral conjunctivitis you can get. For example, the herpes virus is the most common infectious cause of blindness. Uncommon in the newborn period. Erythromycin doesn't prevent that anyway. There's other bacteria that can also get into the eye. I mean, theoretically, the baby is sterile in utero, and when the water breaks, they start coming down, they get colonized. Their eyes, skin, everything gets colonized. But typically, you're given erythromycin to essentially prevent gonorrhea infection in the eye. Now, so then people say, well, I know I don't have gonorrhea.
Right.
Well, you think you don't have gonorrhea because between the time you got tested for gonorrhea and your baby being born, although you think you've in a monogamous relationship, it's possible that maybe you weren't. So we know people go outside of their relationships or they were never even married, right? A lot of people have kids, they're not married, and maybe that daddy's not even involved. So they were negative at 28 weeks. They may have had sexual relations with another person between then and now and gotten infected and not have symptoms.
So the risk, I mean, I can see sometimes when you're saying, they see pain because there's a shot that's given to their like newborn tiny little baby. But with it's an ointment, correct? Yeah. Like a kind of greasy little ointment that just
makes
goes
the eyes
over the
look
eyes.
goopy. It can cause a little redness for a day or two.
And it's just one time, right? They just put it over
it's just a ribbon here, ribbon there, and you're done.
Yep. Do you have to ask, like, when the baby gets delivered? Because again, when I used to deliver and I would hand them off, the neonatologist, pediatrician, whomever was in the room, they take over, right? Do you have to, or are you meant to? I guess you're supposed to, but I'm just asking, is it, hey, we're going to give your baby this ointment? Or do you guys know before you walk in the room that they do or do not want the ointment or a shot?
Usually the initial triage transition nurses are taking care of that before the delivery ever. Now, of course, sometimes people just come and plop the kid out. But in general, most families want those things, right? And the families that either don't want one or part of those are coming in and they say it right away. I don't want my baby to get this. I refuse this.
So they're coming in saying, I don't want it, but no one's coming in going, make sure I get this.
Sometimes they do. No, there are people that more people do that. More people want that, and they want to make sure their baby's going to get that. We get caught up in the noise of anti-vaccine people, people making noise about whatever it is, whatever misinformation and lies. But actually, most people want those things, and they know that they're safe, and they know they're good for their baby. So yes. But we don't think about those because they're not causing trouble, right? Sure. The troublemakers are the ones that are refusing things. They don't know why they're refusing stuff often. And they're very adamant that we're trying to take their baby, or we're making them get a C-section, or all these things that people spin around, and they make a lot of noise. So we only think of those people. We don't think of all the people that are saying, oh no, definitely make sure my kid gets that, because you would consider that normal behavior, right? Sure. So anyway. So yes, erythromycin in general is benign. It significantly reduces gonorrhea, less effect on chlamydia, maybe a little bit on the other bacteria. That's the main things though. So now there are recommendations that if you know you're gonorrhea negative, and particularly if you're having a scheduled C-section, there's zero risk of transmission. If you're not going through a vaginal canal, if you haven't been ruptured and in labor or dilated, you have a closed cervix and getting a C-section, zero risk. Right? Same thing with group B strep. Zero risk. It's not an ascending. Again, that's assuming that you know for sure that person hasn't been dilated for 3 weeks. Right. Sometimes you get people that are dilated for 4 weeks or whatever, and they're still having a C-section. And again, it doesn't apply to the person that has is trying to have a vaginal delivery but fails to progress, or has the C-section for whatever reason. That still carries a risk. So, but there are recommendations, or one option is to say, well, I don't have gonorrhea and I had a C-section, zero risk. Okay, it's probably reasonable. You know, you're saying, listen, my baby can't have gonorrhea. I 100% know I don't have gonorrhea, and I just had a C-section without labor. No way. Yeah. Okay, that's reasonable. That's not. I mean, you could be a reasonable person and not be anti-vaccine and everything. Just say it doesn't make sense. You're giving my kid erythromycin when I'm telling you there's no way. Right?
It's like people who are getting into the ROGAM thing. If people know I'm this type of blood and my partner's this type of blood and this is our baby, and you can prove all of those things.
If you can prove it, right?
Those are the people that are like, yeah, we don't get ROGAM because we know all of these things.
Yes. But you have to really make sure of all those
paternity
things.
Is not certain all of the time. And I've been in those situations as a provider where there's the question later of, this might not be his baby. What do I do?
That happens.
That happens. So we have to think about that as providers. Not meant to be judging anyone, but just thinking we want the safety of the baby.
We're trying to do the best thing for the baby. And we can talk a little bit about ROGAM later too, because there's become more problems with that too. Yeah. So that's erythromycin. So again, you're trying to mainly prevent gonorrhea, chlamydia. It's given every baby because instead of trying to triage all the different things in a short amount of time, right? You're at the hospital, somebody hasn't taken care of you that whole pregnancy, that nurse doesn't know you, trying to figure all this out, and you're having a baby soon.
Yeah.
It's so much easier to just give it to every baby. It's a low risk. You never, because what you don't want to is miss someone, right? You don't want to miss the person who has gonorrhea and you didn't give the baby erythromycin.
Because the side effects of this could be deleterious. This could be blindness.
You could lose the eye. You could literally go blind or have ulcerations of the eyeball.
So it's not like, oh, the risk could be
a watery eye.
Right. Like this is a big possibility of risk.
Yeah, it's a big, gonorrhea in the eye is bad.
Big. And then the big third thing, because this has been a topic for many years, a friend of mine in medical school, when I was a resident, his dad was a pediatrician. He was like, a lot of patients are refusing vitamin K.
Yeah.
And I was like, really? I didn't know that was a thing. I thought that people would really want to get it to be on the safe side. So with that being said, what is it about that has made that so concerning for parents in getting that one?
Yeah. So let's first talk about why babies are given vitamin K. So babies are born with relatively low levels. I don't like to say the word deficiency because then people are like, well, babies are just perfect when they're born. Of course, I can attest to that's not always the case, but regardless, they're born with relatively low levels of vitamin K compared to what they will be. So they're relatively deficient. They don't have a true deficit, but they're relatively. Vitamin K, one of the ways vitamin K is made by bacteria in your gut. Well, babies are born without bacteria in their gut. They have a sterile gut, so their gut is not making vitamin K. They have low levels. Their gut's not making it right away. If they're breastfed, they're going to have lower levels for a longer period of time. There can be cases where they're also born with low levels because moms may be on certain medications as well.
So it's funny you say that too, just because my maternal fetal medicine brain is clicking in and I do board coaching. And this is always a question that we go through for the boards is that if you have a mom that's on certain types of seizure medications, those could be an issue. And it used to be, we thought that if we gave the mom vitamin K before delivery, it would build up the amount in the baby. But it doesn't cross the placenta well enough to really do that much good. And trying to find that level of vitamin K at a pharmacy is like relatively impossible. And it's a lot.
Yeah, you want to make sure their diet, right? Because they need to be deficient in vitamin K too because of that.
Right.
And vitamin K, we should clarify, the K is not potassium for people that out there. So K is often abbreviation for potassium. This is not vitamin potassium. This is vitamin K is an important factor because it is important for producing some coagulation factors in your body. So it undergoes, vitamin K is important for what's called gamma carboxylation and for 279, coagulation factors 2, 7, 9, and 10, whatever. So if you don't have enough vitamin K and you can't make those coagulation factors, you're at higher risk for spontaneous bleeding. So you have a baby who starts with relatively low levels, doesn't make their own very well if their breastfed is going to continue. And the problem is there's a disease called hemorrhagic disease of the newborn. Now, some of that is not related to vitamin K. Some of it is, or vitamin K dependent bleeding. And there's 3 different types of that. There's that can occur in the first day of life. That typically that baby may have something genetically different about them, or the mom was on a medication that prenatally put them at even lower levels, right? Or they were low and they had a traumatic delivery or something.
Right.
Those are uncommon, but they can happen and be concerning. Then there's the classic form, which happens in the first week of life, which is often mild, but can have bleeding in the brain and other areas, usually not devastating. You can have some spontaneous bleeding, maybe a circ that bleeds longer, an umbilical cord that oozes a little bit longer, usually not severe, but can be. And then really what we're mainly trying to prevent, is the late onset hemorrhagic disease of the newborn, which can occur for 6 to 12 months. And that unfortunately can cause devastating bleeding in the brain and death.
So is this more concerning in preterm babies, term babies, or all comers are going to be at this risk?
All comers, but it's rare for parents to decline this for a preterm baby. But if you had a late preterm kid, for example, like most kids in the NICU, it's uncommon for parents to decline those things. I mean, we're doing so much to save that baby anyway. This is a critical part. But let's say you have a 35, 36 weeker that was never in the NICU. Yes, they would be at higher risk.
Yeah.
So that, first of all, that's what vitamin K is. It's an important factor for producing some of the coagulation factors. Also, they have low vitamin K stores in their liver. And again, if mom was on certain medications, they may have even further lower stores. So vitamin K is given to prevent that. Now, why do parents decline it? Well, there's a couple reasons.
And it's just a shot, right? Like
it's just a shot. Yeah, quick and easy, no side effects, right? Okay. There are reports of anaphylaxis. Now, the problem is that this vitamin K box is not just for newborn. It's for all people. The warnings of anaphylaxis, which is an allergic reaction that can be lethal, essentially out of the millions and millions, if not billions of babies that have received vitamin K, there may be one report of a baby somewhere in some country that had anaphylaxis. It's very rare. Are there adults that have it? Yes, that has happened. Let's say you have an adult that was in a car accident or they have some bleeding disorder, whatever, and they have to get vitamin K. Very different than a newborn getting it. Okay.
And I would assume someone like you mentioned that's getting vitamin K as an adult is not getting it for prevention's sake. They're getting it because something bad has happened or they have some kind of underlying medical
medicine,
condition.
maybe their diet, a malabsorption syndrome where so it's a fat soluble vitamin.
Right.
So there are disease states where you may have malabsorption that you need extra vitamin K. So that's one. And you hear black box warning. Well, how is this approved with a black box warning? Well, every single medication has an insert. There is no medication that exists that doesn't have a package insert. You go to the store and buy Tylenol, package insert, ibuprofen, package insert. I mean, more people have died of water intoxication than have died from vitamin K shots. And I'm not kidding. Water at excessive amounts will cause death.
Yeah.
So should you not drink water? I mean, we can't live without water. You actually can't live without vitamin K. You have to have some vitamin K. Water will kill you when drinking too much. Right?
Yeah.
So everything in life at excessive amounts Tylenol. A normal dose of Tylenol isn't going to kill you. But yes, you can overdose on Tylenol.
Absolutely.
Normal dose of water is not going to kill you, but you can overdose on water. So one is black box warning. There were concerns years ago about potential relation to leukemia. That has been debunked. Okay. A large studies have shown no relationship to leukemia. So black box warning, leukemia. There are preservatives is another thing that get people concerned about in any of this stuff. Preservatives. They'll ask questions about, and there's a couple different manufacturers of vitamin K. But along those lines, even with vaccines, you start getting into questions about aluminum, questions about mercury and different forms of mercury. What I find often is they don't want to give it, but they don't know what it's used for. So you've read something on social media, you've heard some warning, but you didn't actually ask, well, I wonder why they give vitamin K.
Why is it recommended that every baby gets it?
So I've never had a family that has declined it, that when I asked them what it's given for, knew why it was given. So you spent 9 months, let's say, full pregnancy, saying, I'm not going to give my vitamin K because I heard this. But at no point in that time did you ask yourself, I wonder why they give that to babies, right? Because if you would read why they give it, you would say, oh, I guess that's really important. Not that these concerns parents don't have aren't unreasonable. I think it's always good to ask questions. Sure. But you always have to weigh things out. And again, I mean, there's 150 million births worldwide every single year, and yet we're not seeing these kind of reports out there.
Has there been a decrease in the administration of it in the last few years?
Yes. And that part,
the decline?
Yeah, and we're post-COVID area. A lot of people feel bothered that they were forced to get a COVID shot, or they interpret misinformation. There's people think that millions of people died from a COVID shot still. So there's a mistrust of pharma. They made these COVID vaccines, but they made billions of dollars. And, everyone, again, not that there aren't problems with the pharmaceutical industry. We know that. But there are also really good scientists that are doing things to save lives, right? There's a lot of medications out there that save lives or make you feel better. Not everything is bad. So, but whether it's a combination of political, government, election, all this kind of stuff goes together, right? Now, all of a sudden, we're talking, political parties aren't just divided by raising or lowering taxes. Now it's science. That was never an issue years ago. So anyway, sometimes they're asking about preservatives in there, and that goes true for vaccines. There's no thimerosal, which is ethyl mercury anyway in vaccines, in childhood vaccines since 2001. But ethyl mercury is not methyl mercury. You have to include the first part. You can't just say mercury. Methyl mercury is not good. Ethyl mercury has never been shown to do anything. But they took it out of all the vaccines.
Who started all that? That was the Jenny McCarthy. Didn't she do some book?
Well, but there was also that guy out of England who had written stuff that vaccines and autism
Yes,
and
that's been
vaccines. And then, of
huge.
course, there's JFK Jr. spreading information, but making a ton of money on all of his books and everything, right? So they'll give money to these guys, right? Because they're revealing all the fraud and everything that they think is going on. Meanwhile, these people are pocketing money on their books and their special formulations of herbal supplementation and whatever it is. So,
which is that also, how you mentioned like everything has a black box warning, or excuse me, everything has a package insert, right?
Everything has a package insert.
So when individuals say they don't want a type of vaccine or something that has data behind it, however, they like to be natural and are okay with things that are coming from the grocery store, but they don't have a lot of data behind it.
And you actually don't know that what says is in there, right?
That's the other thing.
Because it's not regulated.
And, I'm all about if we can help your headache with magnesium, that's fantastic. But I also have to tell people, you got to look at studies that you have that are pharmaceuticals, and then we have information on it. And a lot of things that are vitamins or minerals that people feel are natural can still be like a blood thinner. Like there are people that take things that are natural, but their heart rate goes up, right? Or they take things and their blood gets really thin.
If you take too much niacin, you could die. You could vasodilate and literally pass out or die.
Yeah.
And niacin is natural, right?
Yeah. So it's you still have to look into those things, and it's hard to find that information. Like there are some websites you can go to that are like, they're not government websites for the natural stuff, I guess you could say, quote unquote, but there are places to go. And that's where I try my best to, when someone comes and says, hey, I'm not going to take this prescription medicine, but I want to take this that is natural or that's organic. I've got to do some research because I'm not going to necessarily know about that medication.
And just because it's natural doesn't mean it's safe.
Right.
One, it may not be effective, but two, that it's even safe. And it also doesn't have side effects, right? Because everything originates from something biologic, right? We can agree. Everyone should try to eat healthy. Everyone should exercise and eat healthy foods, less processed foods. I'm 100% for that. Breast milk should be the best thing for babies. But we also have to deal with reality. We have a growing population of obesity, people that aren't eating well. We have populations of babies that can't get breast milk. They're adopted. Moms were using drugs. The mom doesn't make milk because she's older, has a health issue. You have to have formula, right?
Mm-hmm.
They're just kids that can't get breast milk. And so we have the realities. And of course, baby can't just eat well and exercise, right? So it's something different about babies. But we should clarify that I'm all for all those healthy things that people do, but that doesn't necessarily overcome or prevent some things.
Yeah.
It improves chances for whatever it is, but it's not a fix it for everything. It doesn't mean if you eat well your whole life and exercise that you're not going to have a heart attack or that you're not going to get cancer. There's no guarantee.
Yeah.
So there are things for newborns. Like one of our missions as a pediatrician, as a neonatologist, is to fight for the baby when they can't fight for themselves. And parents don't always make the best decisions, right? Yeah. Sometimes moms are using drugs, right? They didn't make good decisions during the pregnancy and they don't make good decisions after birth. So in general, though, I believe parents should have the right to make decisions that they feel are best for their children. There are many examples where sometimes parents don't. And so we always want to ensure that the safety and wellness of a child when they can't make that decision themselves.
Yeah. And when you mentioned all this stuff too, I looked and I brought these with me because you're going to find this fascinating. I think I sent them to you too. I was trying to figure out if I had a patient in my office and I wanted to get them information. We always go to our college, right? Like you have a college of neonatal stuff. What's it called? What's your neonatal college called? Or is it AAP?
Yeah, the American Academy of Pediatrics, kind of, again, the umbrella of.
So then our umbrella is American College of OBGYN or Obstetrics and Gynecology. We all have like a place we go that's like our Bible, right? Like it's like our place we would send patients for patient education. And that's where you go and they take the data and they put it all in their current recommendations, right?
Yeah.
So I went to ours trying to find stuff and check this out. So this is the postpartum care team. And it just kind of says pick a pediatrician kind of, I guess, right? That's really it. My point is, this is like vaccines during pregnancy, nothing about what the baby would get after. But it does have stuff for Tdap, which is great, which is tetanus, diphtheria, and pertussis, whooping cough.
Right.
So we like people to get that because then the baby can get protection.
Right.
Right. And I think
we should clarify that, vaccines stimulate your immune system to make antibodies. And in this case, those antibodies can cross the placenta to the baby. And the baby has those antibodies in their system that if they then after birth in the next whatever months were exposed, you kind of threw something in the pool that their immune system doesn't have to make the antibodies. So it helps get rid of it. fast.
So that's the Tdap is the big one that we always talk about. And you have to get it in every pregnancy because each baby needs that protection, kind of like, or added help, as you were saying. The new one that's coming out is for RSV.
Yeah, the RSV vaccine.
And the latest I saw, depending on when this airs, is that it has been approved by the FDA, but we're waiting for the CDC to make some more of a stance with regard to pregnancy.
Yeah, it just is approved. And we should clarify there's two new things. There's an RSV vaccine. And again, a vaccine is putting something in your body that tricks your immune system into think it's getting sick to make antibodies and other immune factors that if you were then actually exposed to the virus or bacteria, you could fight it. An antibody.
I'm glad you say it like that, because when you say it and people are like, I got sick after I got a vaccine or I had a symptom.
You should have symptoms because your immune system is acting up.
Yeah.
So if you get the flu vaccine, you feel like you got the flu, that's your immune system acting up.
Yeah.
That's why you feel crappy when you have the flu. It's not the flu, it's your immune system, releasing all the cytokines and all these immune mediators. There's another separate thing that was approved for babies that's not a vaccine. It's a monoclonal antibody. That's different. That's not stimulating your immune system. You're kind of like tricking it and going like, I'm going to dump some, it's like putting sugar in the coffee. I'm putting antibodies in their body so that if RSV comes along, those antibodies are there to attach to the RSV virus. The immune system doesn't have to do anything other than then clear it. But normally what would have to be, it'd have to be exposed, start making antibodies. We already feel bad by that time, or you're sick. This way it helps prevent them from getting very, very sick. So it's two different things. Like for adults, it's a vaccine. For women in pregnancy, it's a vaccine. For babies, it's the monoclonal antibody. So, which can be confusing to people because it's all being kind of released at the same time.
So the babies then, they don't have the opportunity for the vaccine at all?
Right. They're not getting the vaccine. They're getting the antibody. Yeah. Yep. And it's called Beyfortus, I think. Beyfortus is the name. There was a shot that's been available called Synagis, which again is also an antibody shot, but that was for very preterm kids.
And now it's for all comers.
Yeah, essentially that. And it was really expensive. So this new Beyfortus is once a season for all babies, and it's a lot less expensive.
Okay. And is it pretty much available now?
It's available now, but it was just released and it was approved. So everyone's trying to scramble to figure out when and how to give it, because it's recommended to be given in the first week of life during RSV season, which typically is like November to March-ish, plus or minus. It was weird during COVID, but let's say we go back to the normal, everything kind of goes back to where it was. Typically, RSV starts trickling up November, December, peaks January, February, and then goes down, just normal cycle.
Yeah.
And eventually affect enough people and they have their yearly immune response that protects them until the next swing. And every virus and bacteria is different. It's hard to overgeneralize, Like the flu changes every year. RSV doesn't change as much. So
people had it. No, I don't feel like most of the general population knew much about RSV until recently, whenever so many babies got sick.
It's interesting. A lot more adults actually die of RSV. Older adults. Everyone thinks of RSV as just a baby virus. We all get RSV every year. Most of the time, we just don't get that sick.
Yeah.
If you have reactive airways like I do, you may act up a little bit more. But, most people actually die of RSV are older adults. So that's why this vaccine was just approved for 60 and older. But people don't even realize you can get it.
Yeah.
Like, I thought only babies got it and got really sick, or young kids. No, everyone gets RSV. It's one of the viruses that goes around all year round. And you feel like crap. I mean, it doesn't feel good. But most healthy people don't get sick and die from it.
Yeah.
But babies that were born very premature are higher risk. But here's the problem. 4 million births a year, more than 10% are full term. So more than 3 million babies are full term. Well, if you take 3 million babies exposed to RSV and you take less than that, just sheer numbers, who's going to be more of the kids that actually get sick? The term kids, right?
Yeah.
Or if you look at adults, right? So if you just take the bigger pool, there's a higher risk. So yes, very preterm kids, less than 29 weeks, are highest risk. So if they were to all get RSV, a greater percentage of them would get sick or potentially die than a 40-week baby.
Yeah.
But just because of the sheer numbers of 40-weekers born compared to the sheer numbers of 23-weekers, you got a lot more kids to actually prevent. And again, you may still get sick, but the likelihood you'll end up in the hospital in the ICU on a ventilator or die, right, is significantly less if you've gotten this, new antibody shot.
Yeah. Well, so this is going to be one, because I've seen some stuff, again, on social media where it's like, ask your doctor to get the RSV shot while you're pregnant.
Yeah.
We don't have that yet. Now, when this gets on the air, maybe we will.
I mean, this could be different tomorrow or the next day. This is like just
constantly changing. And even if that vaccine is available, does your physician's office or provider's office even have that vaccine?
Yeah.
But it's a lot of questions to ask with that. And another thing too is like this space of vaccines, especially for things that are available for a neonate, as opposed to like, oh, the 6-month checkup or this something like that. I think this is a space where we as OB providers in general need to get better at educating patients.
Yeah, I think, really, and get back, I really do think you have not you, but the OB has a relationship with the family for 9 months. You have multiple visits. One of the most important things, other than saying your baby looks cute and look at them move, is how do we plan? Because you're there to get a healthy baby. So there should be ongoing education of vitamin K, erythromycin, hepatitis B, the things that are going to be given to your breast milk and breastfeeding. Mm-hmm. These are all the things that are going to help your baby, not just how are you feeling today? Your kid's so cute. Are they moving?
Yeah.
Let's do a little ultrasound and see how cute they are.
Well,
and then boom, you're on to the next person.
It's the postpartum period that is just like this desert for pregnant patients. Because when they're delivered, it becomes like a lot about the baby in the room. All of a sudden, they're kind of neglected after this delivery. Sometimes everybody goes over to the area to look at the baby. And then the care they receive across the board is confusing to them. The insurance goes away sometimes after 6 weeks, which is like awful for them. But that's the part that it's just, they don't know who to call because the OB's not going to know what the kid needs to get for vaccines. Maybe they haven't established care with the pediatrician. The neonatologist was in the hospital, but doesn't have an office.
Or we never saw them.
Never saw them.
I take care of the kids in the NICU and then only go to certain deliveries.
Exactly.
So the most of the time I don't, at our hospital, almost 6,000 births a year, less than 1,000, me and my team are actually involved with in some way. So there's, they should see the baby should see a pediatrician within a few days of going home. That's what's recommended. We can't guarantee that, but that they should see within 1 to 2 to 3 days, depending how long the baby's in the hospital. But you don't want to leave it to that visit for them to be talking about vitamin K and erythromycin, right?
Exactly.
It should really be, if you got 9 months to talk about it and find out what are their concerns and dispel all of their myths so that it's not midnight, you're coming in for an induction or whatever, and they're like, I don't want this for my baby. Well, do you know why it's given? No. So you've been seeing your OB for 9 months and no one actually went over why we give erythromycin?
Right.
So you can see why it bothers us, right?
Sure.
They're your friend for 9 months. You didn't talk about that? You're just going to stick it on us?
Yeah.
So I think there's a lot of missed opportunity for education, both in terms of maternal diet, maternal health, but also these things like, okay, your baby's going to be born in 4 or 6 months. These are do you have any concerns? No, I want my baby to get all of that. Great, done, boom. That's what most people are going to be, right? Mm-hmm. But you're going to get the occasional people that are going to say, well, I heard this about vitamin K, that you can dispel those myths. Mm-hmm. And again, there's resources everywhere.
Yeah.
The CDC, I would say, is the main one. I know a lot of people, again, COVID messed things up. People now are like, Fauci, CDC, they don't know this, that. And I know there are concerns, but the CDC is still an outstanding resource for a lot of this stuff, for a lot of infection-related stuff. They have a great resource. They don't have malintent. Regardless of how you feel about COVID vaccines and all that kind of stuff, it is still a fantastic resource to go to as the primary, and more so than the ACOG and the AAP.
Yeah. Right? Oh, for sure. I even looked when we mentioned that and talked about that earlier today. They have these wonderful, I think they're nice because they're like color-coded.
Yeah.
I'll put those below for links for you guys. And they update them regularly. As far as I know, they have phone numbers on there. If you have a reaction to a vaccine or a concern about a vaccine, there's places to go for that. It even talks about the polio vaccine on here. I mean, it's got a lot of good stuff. It tells you what are the disease complications, right? So like if you don't get this vaccine for whatever it is, but you get the disease, what could happen to you, right? Like hepatitis B is on here, chronic liver infection, chronic liver failure. I mean, all those things. That's the kind of kid one. And then the adult one here has tons of little notes because it goes all the way to the end of life. I mean, so once you hit 65 and above, what's recommended? Mm-hmm. So it's all on their website. And they update it really well too with like outbreaks. So like if there's a listeria outbreak or some kind of an outbreak in your local area, you can look on the CDC website too. I think it's great.
Yeah, that's my main.
I like it.
That I start with because I think that's going to have the most accurate and thorough information, but also presented in an easy to read way that you can then go into multiple levels of depth. There's a parent level of reading and understanding. that would be always my first go-to, and then go from there.
Yeah.
The last place to start with is somebody's Instagram post, somebody's Facebook post, the mom's group, the twin group that, well, somebody here said that. And somebody says, well, I've been doing research on it. Okay, you've been doing research. You're not a healthcare provider, and you've never actually taken care of a patient. You may be really smart. Maybe you have a PhD and you know how to read all the statistics and everything else. You still have no clinical experience. You've never taken care of these things. You've never seen a baby die of strep pneumonia or pneumonia after having chickenpox. You've never seen somebody have meningococcus and lose their legs and their arms. You've never seen these things.
Yeah.
So, and I'm not making money from the pharmacy companies. There are bad stories. You have all this, the Sacklers and the OxyContin, codeine, whatever the stuff. Yeah, there's bad things that happen, but most people want to do good and aren't profiting from it. I don't make money because I gave your kid erythromycin. It doesn't help me in any way.
They don't make movies about that stuff. They make movies about the bad
right.
people that did the bad stuff that made the money and kind of caused a ruckus, right?
Yeah.
That's what people see.
And then it creates distrust, you know,
Yes.
and so we're in an interesting area across the board, whether it's in school, we're having school board wars. We're politics and anti-vax science it's a crazy time to be in. And, we need to unite, not divide. People can have different beliefs and still have common goals. We all want the best for our children, whether it's in schools and stuff. We have maybe different views of how to get there, but they shouldn't be as divided as they are right now, creating volatile environments and things that are going on that are really unhealthy for the kids in the school systems and for healthcare providers. I mean, there are pediatrician practices that one of them, they won't actually see babies that didn't get vitamin K. They refuse to see them.
Oh,
Because that is saying you don't believe in the science that our practice supports, and therefore we're not the right practice for you and your family.
are they getting pushback from patients on that?
I think they just say no. I mean, and same thing with vaccines. There are practices that won't do alternative vaccine schedules. They say, no, we won't take you if you either don't do vaccines, but we also won't take you if you do an alternative vaccine schedule that you make up, because you can't run a business. You can't run a practice that way where everyone's doing something different. You're going to miss something. You're going to have errors. You're going to mistreat babies and not do justice across the board for them. So their practices say, if you do not follow the recommended vaccine schedule, I'm sorry, we're just not the right practice for you. You have all these other practices you can theoretically go to, and that's where you stand up for science. You stand up for science and what's right. And because you're a medical practice and you're trying to do evidence-based medicine, you stick to that. And I think there's enough patients out there, but I think that's commendable. But I was even surprised at the vitamin K.
Yeah.
They said, no. I mean, if you're at that level where you're refusing that level of science, our practice is not for you.
Can you find that, you think, online, or would you have to go into the practice or call them to find out?
It probably vary by their website.
Yeah.
Yeah. But, that would be for a parent to ask, say, hey, I don't want vaccines of vitamin K. Will you see me? Nope. Or they're going to ask. They're going to ask when
before
they make the appointment.
That's true. That's true.
So, again, very small number making a lot of noise, but the number's getting bigger. And what concerns us is that it starts with vitamin K, hemorrhagic disease in the newborn. People are going to start refusing polio vaccine.
Mm-hmm.
What happens if polio starts creeping back?
When do they get the polio vaccine? The first, when is that?
The 2, 4, and 6 month shots in there. And again, there's different combination vaccines and stuff. There used to be an oral polio. There's oral polio injectable. So there's a mix of things, but
and there are a lot of vaccines. So it's good that pediatricians exist, because otherwise, if you had to keep up with it as a parent on how frequently you have to take your kid in, it's a lot of appointments.
Yeah, I mean, it ends up being like around 3 shots when they're given together. Again, there's different combination ones. And they're given twofold. One, because they're childhood infections that we can prevent. So one is you give these vaccines in the newborn infant period in the first 6 months, because they could get exposed to it and actually get that and get sick or die. And then there's other ones because they are beneficial for life or for many years. The hepatitis B is mainly because of down the road. Again, not including the mom who has it, but for the majority of them. Pneumococcal or Prevnar is because you can get strep infections in the newborn and infant period that can make you very sick. Haemophilus influenza B used to be the most common cause of bacterial meningitis that caused brain damage and death. And in populations that don't vaccinate against that, they still have that. Polio in our country, low likelihood to zero exposure in the infant newborn period, but there's world travel. If people start vaccinating less, it's going to increase. And then polio is devastating.
Yeah. Someone
You
said
know?
recently, they're like, I've never really heard of polio. I'm like,
You don't want to hear of polio.
there's a reason, because you don't really see it anymore because of vaccination.
So we've had this swing to where all these diseases exist. Now a lot of them are very rare. And so we don't want to get to the point where we have to say, I told you so.
No,
I told you if all you people stop vaccinating, this was going to happen. And now it's happening. And now we have something. And, we didn't know with COVID how bad COVID was going to be. Unfortunately, it didn't infect kids very much. And most kids didn't get that sick. And that's good. But we didn't know that at the beginning. Yeah. What if Ebola got in the United States? How would that look?
Yeah.
You bleed to death. Your organs disintegrate. I mean,
I don't want to find out.
Right. But we didn't know when COVID came out, like how bad it was going to be for young kids and children. No. You didn't know. So not that millions of people didn't die and it wasn't concerning, but we didn't know when we were doing the mask mandates and the social distancing and all that stuff. That was to save lives because we didn't know how bad it was going to be. Ebola comes around, we know how bad it's going to be. And if you're not wearing masks and gloves and protecting yourself, half your family's going to die. How does that look?
Yeah.
Serious, right?
Yeah.
So we've grown up in the United States where we haven't been exposed to a lot of things. We're lucky. And we're lucky because vaccines have been around. And if we get to the point where you hit a tipping point, then Planet of the Apes isn't going to actually be that unusual. I mean, actually, COVID was Planet of the Apes. It just didn't happen that way, right? Somebody got on a plane, spread it throughout the world. I mean, if you watch that one Planet of the Apes from like 10 years ago, I just watched it. Literally, it's someone in a lab got something. I'm not saying COVID started in a lab, but let's say wherever it started, right? Then they went here, and then they went there, and then that person went here, and then that person went to an airport, and all of a sudden it just boomed around the world. That's what happened with COVID, right? So imagine that would happen with something like Ebola or something that would be awful.
Was that the last maybe 10 years ago is when it was?
No, but the one where they showed that the first scene was how it spread across the...
I think I saw that when I lived in a foreign country and it was in a foreign language, and I don't really remember it very well. But it was exactly like, I mean,
the first scene, the movie started.
I remember that part.
It trickled out.
All the little
and at
bits
the time,
and
you're like, and then when COVID started, you're like, holy cow, this is exactly how Planet of the Apes started.
Well, one of my most, I think, interesting things to hear people say about COVID still is I got COVID and I know I got it from this trip or this person. Like they could just identify, even if that person didn't have it. They're like, well, that trip to Mexico or that, you know what I mean? Do you have anybody in your family or friends? They're like, I know that's how I got it. Yeah. It's interesting.
And it still was. I had it after being vaccinated. I got the vaccines. I got it, still got it. And I lost my sense of smell. It was a year and a half.
Yeah.
And I don't think I have true COVID fog, but sometimes I'm like, I just don't think the same way I used to. I'm a little more grumpy than I used to.
I can blame a lot of things on having had COVID. I'm like, I forgot my shoes or something the other day. I'm like, I did have COVID a couple of times.
I got COVID.
Exactly. Well, I think, I know we went on lots of good tangents and I think a lot of educational things, but is there anything else that we didn't hit on or touch on to where you're like, I really want to make sure, since I have the ear of some pregnant individuals or people in the healthcare that are in the world of pregnancy, that you're like, I really want to just share anything else just in case we didn't touch on it?
Yeah. I mean, there are a couple common things, I think. So just to give you a generality. So we talked a little bit about limits of viability, which is somewhere around 22, 23 weeks. Mm-hmm. That with the technologies we now have available, that we could technically keep a baby alive. Now, keeping a baby alive and long-term quality of life, if they survive, are two different things.
So when you say this though, because when it's the 22 to 23, in my brain, we used to have 24 as quote unquote viability.
So we used to say 25 weeks and above was unethical to not try to do everything.
25, it was 25.
Now that seems to be moving to 24, where we almost don't give parents a choice. You have to resuscitate your baby. We have to do everything we can to keep your baby alive. If something bad happens, we'll address it. So we're pushing those margins, right? Week earlier. Now people are starting to resuscitate 22-weekers with varying levels of... At some point, we will hit a physiologic that unless you create an artificial uterus tank or something, just no way. I mean, technically at 22 weeks, the blood supply that's going to your air sacs, and your air sacs are not connected. But somehow some kids survive. So your air sacs are called alveoli, and blood vessels that bring carbon dioxide to them, and the blood vessels that take oxygen from them all to your body technically shouldn't be able to support life, but they do. But anyway, so we take care of, as a neonatologist, I take care of kids from that very limited viability through full term. Now, In our NICU, most kids actually aren't that premature. Most
Mhm.
kids are late preterm or term, and most of them actually come into the NICU for something parents don't expect, which is retained lung fluid. And I bring that up because it distresses the parents because they weren't expecting it, even though
Yeah.
the kids are going to 100% be normal and have no problem. And so the lungs make fluid. The lungs are actually expanded in utero, but they're full of fluid. They're like if you put a sponge in a bucket of water. The sponge isn't crumpled up, it's fully expanded, right? And the lungs actually look just like a sponge.
That's
What
such a good analogy. You have really good analogies, by
I
the
got
way.
because
Like really
I
good.
did the dishes at home. Honey, you better start doing. But so this is the way I describe it. They make fluid. The lungs are waterlogged. Normally, if you don't get induced or everything, you just come in labor. The lungs have actually shifted from making fluid to absorbing fluid. So once the baby's born, they just have to cough the fluid out of their airways. The sponge is not dry because it's in the body, but it's not waterlogged. Okay.
Yeah.
But if you have, let's say, a late preterm birth for preeclampsia or whatever, you have a scheduled C-section at 39 weeks, never were in labor, and now all of a sudden your baby needs to come to the NICU, the parents are devastated. They think their baby's going to die or something's wrong. So retained lung fluid essentially is you have a wet sponge, you did the dishes, it's soaking wet, and you haven't squeezed all the water out. If you just put it on the countertop and you're in Florida, that's going to take a couple days or may not dry out. If you're in Arizona, it'll dry out quicker. If you squeeze most of the water out, and it moves normally, well, it's going to be fine. And so when I explained to parents, I said, listen, your baby's lungs are like a sponge. The lungs are waterlogged. Your baby could be off this oxygen in 2, 4, 6 hours, or could be here 7 to 14 days. We have some kids that are in the NICU for 2 weeks because it takes them that long for their lungs to fully normalize, come off oxygen and work normally, to have the normal compliance. Lungs don't open and close. They're open all the time and they go like this. So retained lung fluid, or what we call transient tachypnea in the newborn, is actually one of the most common reasons kids come in our NICU. But the parents don't see that. They see most of the preemies, but they're devastated because no one talked to them, OBs, that, by the way, when you have a scheduled
There's
C-section,
finger pointing, but no finger pointing physically happening right now.
that, oh, by the way, just so you know, some kids, when they have a C-section without labor, are higher risk to have some retained lung fluid. And your baby could need to be in the NICU.
So this is one thing that when he was talking, I kind of physically made my hands go to squeeze because when the baby passes through the birth canal, I mean, your pelvis is made of bones. So when that baby passes through the birth canal, there's a bit of a squeeze.
There's a bit of a squeeze, but it's not really the squeeze. It's the hormonal changes that change the function of the lung tissue and the epithelium from making fluid to now absorbing fluid. It's not like you're just squeezing the fluid out and then it's going to fly out. And
right.
But it didn't squeeze enough. Now, if you have a fast delivery, it's not from lack of squeezing. It's because the whole labor was fast. And so the physiology that happens during labor that tells the lungs, stop making fluid, absorb it because I'm going to be born soon, was too short.
So maybe when people are upset that they had a long labor, they can say, but I did something good for my baby.
It would be very uncommon to have a baby born to a mom that went through full labor that has retained lung fluid. That's very rare. Usually I get history. Yep, I walked in the hospital and I had 2 pushes.
Yep.
Or I was in labor, but I actually pushed a few times. So that end stage was really fast. Or I had a failure to progress C-section or C-section for distress, or I had a repeat scheduled C-section. It's not, I don't want to say it's zero, but it's rare to say, I came in labor on my own and I labored for this and I pushed for an hour, hour and a half, and the baby came out and they had retained lung fluid. That's not usually the case. That's not the baby that typically has retained lung fluid. It's the very fast delivery or the C-section.
Yeah.
And it's just physiology. There's nothing. I tell them, I say, you're here, your baby has an IV, maybe it has a feeding tube because they're breathing too fast. They're on oxygen. Your baby looks sick. There's absolutely nothing wrong with your baby. I know that sounds crazy. There's physically nothing wrong with your baby right now. You're seeing all this. I know that sounds crazy, but I'm telling you, there's nothing wrong with your baby. This is a physiologic process that we have to support your baby until they do that.
Yeah.
And that's going to be hours, days,
Yeah.
And when it's done, it's done. No long-term effect. They're going to be fine.
Yeah, I think that's one of the biggest things too, is that no one wants to have a baby in the NICU. It's not a place that you want to be. It's not a badge of honor. And when they've had that, they remember that forever. So when I talked to
I had one.
Did you?
Yep. Now I had one of my twins was 35 and 6.
Yeah.
And he was in the NICU for basically a week because he wouldn't feed very well.
Mhm.
But I'm a NICU dad. I was in there and I wanted my kid in there. I was like, I'm not taking him home. He won't wake up to eat. I'm not force feeding this kid.
Yeah.
This was during my fellowship at a different, not where I was training, but a different hospital. And and in fact, they're like 48 hours, you got to go home. I'm like, you won't eat. You got to go home. Fine, we'll be back in the morning. Came back in the morning, brought him to the NICU. He stayed for a week until his switch turned on. He woke up to eat. I'm not going to be at home trying to force feed a late preterm kid who won't eat.
Okay, so this is a great, and we can end on this because I know we've gone for a while, but here's my question to you. As the patient then, I mean, I know was it a son you said that was in the NICU?
Yeah.
If you really felt that you weren't getting the care and you're like, he needs to stay, something's not right, and there was a push, how would you go about talking? Like if you're a parent and you're telling another parent, this is how you advocate and talk to them and not get kicked out, like don't do anything crazy. But what do you need to say, or how do you say, like, listen, this just isn't right? Because you were in the medical field at the time, in that specific field. But if you're just as somebody who you're a teacher or you're a lawyer or something, you don't have the medical terminology, like what would you do?
So these are the steps I would do. The first step typically is you're telling your nurse taking care of you. That's that's first level. That's usually where you're maybe meeting resistance. Then you ask to speak to the nurse supervisor. That doesn't get you where you want to go. Then you say, I want to speak to the physician who, let's say if it's a newborn, maybe just a newborn physician, or it may be the neonatologist at the hospital. But you don't stop. Now, interestingly, usually it's the opposite where parents want to go and you're like, no, you can't go. Your baby needs to be in the hospital and needs to be in the NICU.
Sure.
That's more common. The problem is they're like, you're taking my baby or my baby doesn't need to be here. I'm like, no, your baby can't go home. And I won't let. So one thing is no baby will leave the hospital AMA, which is against medical advice. I will call Child Protection Services and we will get a court order. You're not taking your baby home if I don't think your baby is safe to go home. It's not happening. Zero chance.
He can do that. My field can't do that. We have pregnant patients that leave rather regularly because.
But for a baby, we can do that.
But for a baby,
Because if we think that baby's in danger because they're having breathing problems or apnea events where they don't breathe normally or whatever it is, they're not leaving the hospital. I'm calling Child Protection Services. So anyway, more often than not is the family that wants to leave when their baby's not ready to leave. But if you feel that they're not getting the care, I would take it up the ladder. Your nurse supervisor, get a doctor and clearly voice your concern. And maybe they'll clarify something that maybe you misinterpreted or maybe they reassure you, right? And say, I understand your concern, but let me, from my perspective, or we can watch your baby. And they don't need to be in the NICU, but maybe we can watch your baby another night. But you should always go that route and go up until you feel that you're getting the information. And that's really in all levels. There's a bedside nurse. There's a nurse supervisor for the floor. There's a physician for every unit everywhere in the hospital, whether they're on the phone or physically there. That somebody can be there, that you should never leave an emergency room, a hospital, if you don't feel that something's being done right or you feel your baby or whatever is sicker than maybe they perceive.
Yeah. And what you said for asking for clarification is important, just like before, being clear, because maybe there's a disconnect there that someone didn't understand, or maybe someone missed something. And by you asking, you're going to bring it up to them and they're going to be like, oh, sorry, we didn't realize that this hadn't been done yet. You need to stay another day or something like that.
Yeah. I mean, you should always trust the parent best. They know their kid best, right? You know, I always ask parents, I was like, the nurse was concerned about this line. Does she seem any different to you today? She had some events last night, but no, she seems just as active yesterday. Or the parent may say, she just doesn't seem as active today. That's a flag right there.
Yeah.
I'm going to work that baby up because that mom's here every day.
Yeah.
She knows something different.
Yeah.
But the nurse who was on last night has never had the kid before, but this mom's been here both days and she says the baby's the same. That's going to reassure me. That's going to tell me that baby's okay. But sometimes it's a nurse, right? Sometimes it's a nurse who's saying, you know, I have this concern about this baby. I talked to Dr. So-and-so last night or yesterday, but I'm still really concerned. And then they bring it back to you and you say, you know, I also have that concern, or this is why maybe we're going to continue to watch, right? Yeah. When you present to a doctor something, they don't do anything. It's not that they didn't do anything, that their plan then is to continue to monitor. Monitoring is the best medicine. So sometimes just continuing to monitor rather than starting a medication, doing lab tests, whatever it is, that's not doing anything. That's actually just continuing to observe, right? Somebody comes to your office and says, I have a fever. And you say, well, you look great. If your fever lasts more than 5 days or you have these symptoms, come back. You didn't ignore the fever. You didn't not do anything. But at that point in time, that fever was not concerning to you. Now they come back with a bad headache. And now you're concerned they have meningitis. Whatever it is, you didn't ignore it. You put a plan in place. Now, if you go somewhere and they're like, it's nothing, poo-poo it, that's not responsible, right? Yeah. So it's all how you address it.
Yeah.
Communication, right?
Absolutely.
Introduce yourself. It comes back to...
Always. And I will ask one more question because this is on my brain. Babies, when they are taken home, how should they sleep?
Good. Back to
I feel
sleep.
like that's a big question. So they should be on their back.
Should be on their back.
And where?
In some bed of some sort that they're protected. Now, I bring that up because there's a lot of new things, like there's a bed you can put in your bed that is safe, that you're not going to roll on your baby. But so babies should be in their own sleeping device with nothing else in the bed. Okay. They should have no
fluffy
bumpers,
toys,
no fluffy toys,
blankets,
that are no loose blankets,
bottles,
no hats over their head that can fall over their face. None of that in the newborn period, and not until they're older and they're rolling over. Now, there are devices that can either attach to the side of the bed, or there's what's it called, I can't remember because my kids are 6 and 8 now, but that you could put in the middle of the bed that was hard. It had like a metal frame. There's no way you could roll on it. But a baby should never be in your bed, or you fall asleep with your baby on your chest or in a bed, because I have unfortunately seen accidental suffocation. And that's not sudden infant death syndrome, that's suffocation.
No. So my father is the justice of the peace in Texas. And if your county is a certain size, they have a justice of the peace, and they actually have to pronounce people dead if a death is in a home. And I think he said of 9 of the 10 infant deaths that he's been to, they have been in the bed with a parent.
And that's not sudden infant death syndrome. That's suffocation. It's accidental suffocation, but that's not SIDS.
Yeah.
That's accidental suffocation, which can be prevented. And that by putting kids, the whole back to sleep thing is one, to reduce SIDS, but it also eliminates all accidental suffocation.
Yeah.
Because that baby is in a protected space that no one can roll over or fall.
Exactly.
And so whatever those safe, and there's new things. I just saw some new commercial, something props. That's fine. You want your kids sleeping in your bed with you. That's fine if they're in a safe device that that can't suffocate them. You can't roll over on them. No pillow can fall on them. No pillow can block airflow.
Right.
Whatever that is, that's okay.
Yeah.
But it needs to be a safe sleeping environment for that baby.
Yeah.
On their back.
For SIDS, I have read 2 articles about a test that patients can have that could say, oh, this has a concern that you might have a baby with SIDS. I think it was just 1 or 2 articles. Is that a thing in y'all's world yet, or no?
Not yet. There's
I didn't
some
think
interesting things on like the vestibular system and the hearing that I think somebody out of Washington or Seattle had some interesting theory hypothesis on. There's I'm sure somewhere down the road something that will identify something that the basic idea of SIDS, and again not well understood, is that whatever happens, the baby's not able to arouse from it. So
can you define SIDS real quick for the listeners?
Sudden infant death syndrome is so when a baby dies unexpectedly and every other cause has been eliminated.
There you go.
So you've eliminated the most common, which is suffocation.
Mm-hmm.
You've eliminated congenital abnormalities with an autopsy or known. There are rare metabolic diseases that unfortunately once the baby's passed, you can't diagnose. So you're left with, we've ruled everything else out, and so we don't have a known cause. It doesn't mean there isn't a cause. We just weren't able to diagnose it because we don't have the metabolic testing yet, or we couldn't diagnose the infection or whatever it was. So, but what's been shown to be beneficial is kids sleep by themselves in whatever device on their back. Because although, yes, we sleep deeper on our belly, we're not able to arouse as easily. And whatever that baby's underlying risk is, not being able to arouse normally is what then theoretically puts them at risk for SIDS. So yes, they may sleep better on the belly, but if they get into a state that they're about to cross that line, most people are able to get up, right? Have you ever fallen asleep on the couch? You're like, you choke on your own spit or something, right?
Because your neck wakes you up on a plane.
You're like, right? That's your body's arousal state, recognizing that now you're in an unsafe. What if you couldn't do that? You would suffocate on your own secretions. Yeah. So something with SIDS with an at-risk baby, which we don't know the exact understanding and causes, puts them at risk. So we don't know that, but the data now clearly shows that sleeping on their back seems to improve their arousal state, so that theoretical at-risk baby, which we haven't diagnosed or we know is at risk, you just reduce it in every baby. You're not going to prevent every one of them. But a lot of people hear of SIDS, and it's actually not SIDS, it was suffocation. My cousin's baby died of SIDS. And if you actually delved into it more, it was probably most likely a suffocation and not a SIDS, which is unfortunate. But not that anyone, you don't want to blame people, but it's through education that you say this is not safe. And if you don't do this, your baby's not going to suffocate. You do this, and we've all fallen asleep with our kids on us. I mean, it's the middle of the night, whatever it is, they fall asleep on you. And I unfortunately saw this happen. A baby died. Someone fell asleep on a recliner. The kid went over this way. They woke up and the baby was trapped in here. Right.
Yeah.
And so, it's education for people to be really aware and alert of not falling asleep with their kids in unsafe situations, putting them back to sleep before they ever get to that point. And that could prevent a lot of accidental death, just like fences prevent drownings, right?
Yeah.
Fences prevent drownings, but you got to also watch your kids.
Sure.
Got to keep your eye on your kids. You can't just assume the fence, but they can never get in there. That's a roadblock. But if there's a pool party, you're responsible for your kid and you never take your eyes off them for a second.
Yep.
Unfortunately, you hear these drownings a lot of times is at some pool party. Somebody was talking with someone else. They thought someone else was watching the kid.
Right.
If I was ever having a pool party at my house, there'd be a disclaimer. You're responsible for your kid. Your kid. You need to watch your kid. Your kid, something happened. That's your responsibility.
Yeah. That's hard.
Tommy Lee, I remember the drummer for Motley Crue. Some kid died at his house and it was a drowning because somebody wasn't watching their kid.
Oh no.
Or the that couple, I forgot what they're athletes, they had that baby, that kid that unfortunately died. It was at a party, pool party of some sort, and they were there. And so like anything, it's education can prevent, not all, but reduce it a lot so that, it's babies and people aren't born with everything perfect. We are actually very flawed. Only a third of pregnancies make it past the first trimester because of genetic and whatever else. There are many things that we are born with that isn't perfect. We haven't evolved into some elite species. There are a lot of errors in our bodies. Yes, they're miraculous, but it doesn't mean they're perfect.
Yeah.
And vitamin K is one of them, and other things that, people get that you can reduce. I mean, if it was, then every baby with transient retained lung fluid would die. If I just said, well, your baby doesn't have the natural goods to survive, so we just let them die. Would you let, 1 million babies a year die or 100,000 die because they've retained lung fluid? No, of course not. So this idea that babies are just born perfect and they have all the things they need, yes, most of that is true, but unfortunately it's not always true and they need some assistance in some way.
Yeah. Well, thank you for educating us today on a lot of things. I think, the biggest thing that I'm trying to do here is help people to have a good impact on their pregnancies. And also letting the people know that for the providers taking care of them, that our job doesn't end once the baby's out. And it's really good to try to get some extra education in there. So thank you again
start
for
during the
coming.
pregnancy.
I know. But also
Early.
think about this though. Like, you're asking someone who studied for 4 years in obstetrics and gynecology and got not one day of education about a neonate or a baby, or you know what I mean? Like whatever they had for that was in medical school, not in their residency. And so it's like no one goes to a neonatologist and says, you go deliver these babies and do the ultrasounds on the babies. But I see what you're saying.
Yeah, but there's a
space.
few kind of things. So we're talking about a small number, right? I'm not asking you to intubate a 23-weeker and manage a jet ventilator, right? So, and just like you're not asking me to read an ultrasound, but there is these are vitamin K, erythro, hepatitis B, breastfeeding are common grounds for both of us. So we both need to be responsible, neonatologists and pediatricians and obstetricians, that collectively we're doing as much education as possible for the benefit of the baby and the family.
And this needs is CDC, and CDC is everybody, right? It's not choosing like, I like the OBGYNs or I like the neonatologists.
Right. No.
It's just everybody.
Yep.
But I will tell you that ACOG is not doing a great job on it, and I can work to change that. And then we have our Society of Maternal Fetal Medicine, which is like the little group for the small group of perinatologists like myself. And I can tell you there's not any data like that on our
34
site.
weeks is not term. They should have an article that says 34 weeks is not term.
A lot of big push. We are, and most maternal fetal medicine specialists, the hospitals, thankfully now are putting a lot of big rules on you can't, induce early unless you give me a good indication. I do feel like
no, it's really good now.
15, 20 years ago, it used to be different.
When I first came here, it was like, oh, you made it to 34 weeks. Well, then the kid's in the NICU for 3 or 4 weeks. And the family's distraught. Yes.
Yeah.
They didn't deliver at 23 weeks, but now the baby's still, I don't want babies in the NICU.
Nobody
I love
does.
what I do, but I want babies to go home with their parents. I don't want to admit babies. I don't want to spend an hour doing an admission. I want them to go home with their parents.
Yeah.
Most neonatologists, they don't want your babies in the NICU. They want them to go home.
So you're saying you hate your job?
No, I said I love my job. But there are still babies that are going to be sick and still babies premature that need someone to take care of.
Yeah, for sure.
But I don't want to bring babies in to bring babies. I want to do what I can to keep them with the parents and to go home with the parents safely and never be in the hospital or the NICU beyond the newborn period.
Agreed.
And so that's part of that culture we gotta get rid of, is this increasing, like, well, they're making me have a C-section. They're taking my baby away from me. No one wants to do that. No one wants to do more than they need to for you. They want you to. If every home birth could be perfect, great, deliver it home. The problem is when it goes bad, right? Home births are great if they go great. The problem is when it goes bad at home, the outcome is devastating. If it goes bad in the hospital, there's a good chance the baby's going to be totally normal. I go to a lot of C-sections because the baby's heart rate is tanked and the baby's in distress, and they come out and within a minute they're fine. If that was at home, that baby may be dead. So it's like driving down the highway with a blindfold at night and there's no cars. If you're driving blindfolded down and driving slow and there's no cars on the highway, you're probably going to be fine. You drive blindfolded in the middle of the day, fast on the wrong side of the highway.
Different story.
Different story. That's what a home birth is, potentially.
Yeah.
It could be totally fine and nothing happened.
It's a gamble.
There's a gamble. It's a gamble. So again, the point just being that we want the best thing. We want babies to be healthy. We want them to go home. We don't want to keep them in the hospital. That's not something we desire or get joy out of. We get joy out of helping them get better and doing great. But we don't want to keep them there. We want them to go home. We want the family. I don't want to keep you here. I don't want to have this discussion every day with you. I want you to go home so I don't need to have this discussion with you. I'm not getting pleasure out of this.
Yeah.
So me keeping your baby in the hospital because they're not ready to go home I'm not having fun here. I'd really like if you go home. I'd like if I never have to talk to you again about this.
I'd like you to go now. But no, that's the whole point, is to get a healthy pregnancy and a healthy baby. Yeah. And that's, I don't have it on these mugs, but I always finish up saying, wishing you a happy and healthy pregnancy.
Nice mugs,
but thank you. They're good size, right? But that's the whole point. And now I'm going to have to, you have encouraged me and now given me the opportunity to make a new handout to get information on there about bridging that gap. Because I can tell you, if I'm an OB, boarded in OB and in maternal fetal medicine, and this didn't feel like my wheelhouse, then whose wheelhouse is it to make sure to kind of bridge that gap? So,
and we're just talking about a few things.
I know.
We're not talking about feeding tubes and ventilators and endotracheal tubes. We're talking about these three things that bond us, or four things.
I will dip my toe across this.
Include in there.
Oh, breastfeeding and you know, I will say the Society for Maternal Fetal Medicine and ACOG has done really good about getting out information, education on breastfeeding. Baby steps, right? So like I got off a call today for the Healthcare Policy and Advocacy Committee and no one brought up this. So I'm going to bring it up.
Yeah.
It's going to be a thing. So everybody, thank you for listening. Thank you for coming today so much.
Hopefully I spoke enough.
I think you did. I think you have plenty of good information. And as always, trying to help you to expand your knowledge around any topic. And this was a new topic, even some for me, which if it's new for me and I'm in this field and close to, I know it's probably new for a lot of you listening. Develop some skills on how to ask the right questions, who to ask the questions to, the way in which you can bring up topics that you might have some pause about or need more information on. And then finally, having an impact. I am super excited about the impact this has had on me today because it has opened my eyes into a place that OBGYNs and maternal fetal medicine specialists needs to dip their toe into, and that we as OBs and as MFMs need to be helpful in educating our patients so that they can transition in a better fashion. And hopefully that gives you an impact and a positive impact for you and your pregnancy moving forward, for you to have a healthy neonate and a healthy infant thereafter. So thank you guys again for watching. As always, I'm Dr. Lexi, wishing you a happy and healthy pregnancy.